Our first speaker today is a forgiving sort, the kind of man who publicly forgave me for misspelling his name in the printed program last year, the kind of man who commands respect, the kind of man whose compassion and commitment serve as an inspiration to those he knows. He was born in Nigeria. He received his MD degree from Morehouse School of Medicine, his Master's of Public Health from Emory University, and completed his internship, residency, and fellowship at Emory University's School of Medicine. He presently works in public health and international health and is the medical director for tuberculosis, refugee health, and laboratory services at the DeKalb County Board of Health. He is the CEO of Premier International Healthcare Incorporated, with several HIV projects in West, Central, and East Africa. His national and international affiliations are numerous, including Physicians for Human Rights, the International Association of Physicians in AIDS Care, and the Global Initiative for AIDS Nutritional Therapy. He has worked as a consultant for the Centers for Disease Control and Prevention in developing the U.S. National HIV Prevention Strategic Plan. Please join me in welcoming our preeminent expert, Dr. Alawode Oladele.
How many of you here are under the age of 25? So a significant number of folks. Joe, what about you? You had me fooled. You know, in our culture, or in my culture, life is a journey. And the quality of our lives are really determined by the experiences that we have through our life and the people that we meet and the quality of those relationships that we build. I'm going to tell you about different people that I have met and different things that I have experienced that have helped me in the development of my life. I'll probably be a little bit all over the place today because I had a presentation set up that I'm not going to really follow, thanks to Joe. He wants me to just freestyle this and talk a little bit more about the personal experiences. But one of the key things that we need to remember is that when I talk about the numbers, these numbers represent human lives. Our cousins, our brothers, our sisters, our aunts, our uncles, our grandfathers, our grandmothers, our children, our grandchildren, our partners, our husbands, our wives, our friends, and even when not connected by those relationships, you are connected by that very complex strand of humanity itself. So, our humanity. And so, again, keep that in mind. I will throw a lot of numbers around, but remember that these numbers represent human lives. And so, for me, I start out by paying tribute to the 25 or more than 25 million individuals that have died due to this epidemic. But not only these individuals that have died because they were infected with this virus, but those that are affected by the virus. And that means all of us. all of us. This year in Toronto, over 20,000 individuals gathered at the International AIDS Society Conference. I didn't have the opportunity to go this year, but I can summarize what the outcome was at that conference as far as information is concerned. It's been nearly 25 years since AIDS was given its name, and we have had remarkable advances in treatment and understanding about HIV and AIDS. A potential death sentence has now been turned into a chronic disease, but we're still working on a vaccine. And our wonderful partners from the Hope Clinic will talk to you about vaccine work. We have made remarkable advances in behavioral sciences, in the technology of treatment, but keep in mind that access to some of these wonderful developments is still a problem in a major part of the world. So treatment does keep about 40 million individuals alive, but we still have issues that we are trying to address. Issues having to do with resistance. Remember, we have a virus that really, on its own, is not a very strong virus. It cannot survive outside of its environment. Yet, this virus manages to stay several steps ahead of our science. AIDS is preventable, but in fact, it is stubbornly resistant to modern medicine. And our approach ultimately has to be a balance between developments in human behavior and developments in science. And indeed, we have our hands full. So, what are some of the experiences I can talk to you about that are relative to my life? I was born and I grew up in a nation far away from here, and I came over here years ago to go to school, and I have now developed an infrastructure that allows me to go back and forth. And so I have the opportunity to do what a lot of people might not have, which is to see the side of the coin from two different points of views. I'm able to see things from the side of being or living in a community where we don't have a lot of access, and then I come over here and I'm able to see things from the side of the coin where we do have access, we do have technology, but we are lacking in certain perspectives. I will talk a little bit about that. So, how has this affected me? Well, earlier on in my development, I had the opportunity to do a lot of work back in West Africa. And I have also now had a lot of opportunity to do work here in the United States. And my involvement here with HIV started in the mid to late 80s. And in fact, my first patient with HIV was an individual that I took care of at Grady Hospital here in Atlanta. The patient that I took care of left a memory with me that I will carry for the rest of my life. I watched that patient die in my arms. And it's painful when I go back to my part of the world. In the year 2000, and I go through the same experience that I went through in the late 80s here in the United States, having to watch patients die in my hands because of lack of access, lack of resources. And so, in a way, that is one of the experiences that keeps me going. Joe wanted us to talk about what keeps us going, what drives us, what gives us the passion. Why do we do what we do, and why do we continue to do what we do? And remember, I told you about the experiences that we have through life that keeps us focused. Well, those are the kinds of life experiences that have kept me going. But there are others. There are individuals that I have had the opportunity to interact with, and I'll talk about some of these experiences. One group of individuals I call the unsung heroes, the true foot soldiers in our quest to tame the virus and the epidemic. People like Joe Odom. People like Tony Childs. I don't know if any of you know Tony Childs. He's usually a fixture during the World's AIDS Day conferences that we have in DeKalb County. He's not here with us today because he's under the weather. But those of you who know Tony know that he's one of the foot soldiers. And there are numerous others. These individuals, the quality of the work that they do, have an impact on me keeping focused on what I do. And then there are the big names, the names that we hear about. And for me, one that sticks out or stands out is a gentleman by the name of Jonathan Mann. I'll talk a little bit about Jonathan Mann, but I want us to have a little bit of reflection here. And this is something that I used last year. For this part, I would like for each one of you to read to yourself the lines of this thought from an ancient script called the Sanskrit. And I thought it was appropriate because it talks about hope. I thought it was appropriate because it talks about the past, it talks about the present, and it talks about the future. Isn't that powerful? And so, 25 years and counting, the central question remains what you all will do when your children ask you about HIV and AIDS. The central question becomes how you will transform your lives as a result of this global epidemic or pandemic. Jonathan Mann was born in 1947, and he died in Swiss Air Flight 111 on September 2nd, 1998. This was one of the heroes to me in the course of developing programs on a global level for HIV. Our opportunity is historic. For when the history of AIDS and the global response is written, our most precious contribution may well be that at time of plague, we did not flee, we did not hide, we did not separate ourselves. He was a renowned leader in public health and human rights. But for me, what I take away from the work of Jonathan Mann, and for those of you who don't know, he was the former head of the World Health Organization's AIDS program. He was actually quite unique. He resigned his post to protest a lack of response from the United Nations and other international organizations with regards to AIDS. and the action of the WHO at that point in time. But during his leadership at the level of the World Health Organization, he brought to the table the largest amount of funding ever for a program that was put together, for any single program put together by the World Health Organization. He was a scientist. But for me, what was more important was the fact that he did not think of HIV just as a transmissible virus. He thought of HIV as both a health issue and a human rights issue. And there were three main points that he made and continued to make till the day he died. First, health is a human rights issue. Secondly, human rights are health issues. And thirdly, there is a very complex and tight linkage between health and human rights. And you, in fact, cannot address one without addressing the other in order to be effective. And so for him to improve health, to improve well-being, and to prevent premature death, you have to talk about the overlapping philosophies that are tied to health and human rights. And for the work that he did, he will remain one of my heroes. So, health and human rights, from the perspectives of the global AIDS crisis, I believe is a crisis of our generation. And today, remember I said we do have the numbers, but these are lives. These are human lives. 8,200 people approximately will die of AIDS. 14,500 people will be infected today. And worldwide, we have over 40.3 million people living with HIV. And these are the people that represent my greatest source of motivation to do what I do. They're the lives that I don't necessarily see or touch on a daily basis, but I know they are out there. And the fact that they are out there keeps me doing what I do. And again, in 2005, 3.1 million people died of AIDS. 4.9 people were newly infected with HIV. And half of these individuals became infected before the age of 25. And the rates continue to rise. I'm going to take you on a journey around the world, and we're going to come back to the United States and the community where you all reside. If we continue at the current rate, by 2010, over 100 million individuals worldwide will be infected. And there will be 30 million AIDS orphans worldwide. And again, I tell you, this global AIDS crisis, no matter how you look at it, it is our future. And indeed, it is our crisis. And because it is our generation, it really is our obligation. There are three diseases together that have the biggest impact on our health today from the global perspective. HIV is one, TB is another, and malaria is the third. And together, these three diseases will have the greatest impact on our lives. But it's not like we have not seen diseases and plagues through time. Historically, we have met challenges, and we have risen to the challenges, and it is now up to us to rise to the challenge of addressing the issue of HIV and AIDS. So let's go halfway around the world or across the world. The greater percentage of individuals who are infected with HIV and also have AIDS are in developing nations. 65% of these are in sub-Saharan Africa. But there are other areas that we call second wave areas. Eastern Europe, Asia, specifically places like India, and then the Caribbean. But again, we must not forget the disparities that we see here in our own backyard. Who are the individuals that are infected? Women stand out. Women stand out. Over half of new infections, whether it's across the waters or it's over here, we're seeing more and more women infected with the virus. This is an interesting see if I have a pointer here. Okay, well, no pointer, that's okay. But if you look up here, these are pregnant women who go through prenatal care. And in some parts of the world, what happens is when they come in for prenatal care, they are tested anonymously, and we track the data. And in some parts of the world, over 30% of the pregnant women that are coming in are infected with HIV. You see places like Botswana, if I use the pointer up here, where 32% of the pregnant women between the ages of 15 and 24 are infected when we see them in the clinics. You see places like South Africa, where over time, almost a quarter of the pregnant women that come in are infected. And why is this? Well, again, I think it has a lot to do with human rights and specifically women's rights, or the lack thereof of basic rights for women from a global standpoint. There are other issues: domestic violence, rape, legal oppression, economic oppression, discrimination, denial of equal opportunity or access to education. But it all has to do with women's rights. Who else? The youth. Remember, we talked about the 15 to 24 age range. 50%, both globally and in the U.S., as far as new rates are concerned, those are the people that are getting infected. And what happens Remember I told you about the disparities that we have as relates to access to care and technology. Well, here in the United States, it's extremely rare for you to now see a baby that is infected with HIV because we have the technology to prevent maternal to child transmission of HIV. Yet, with that technology, the sad reality is that 14 million children have been orphaned by AIDS, and a lot of these children are also infected with the virus. One of the most striking graphs that I saw a few years ago was this graph, and to summarize it, what it shows you is over the past decades, the gains that have been made in the life expectancy of individuals in developing nations. So over time, we have made gains, but because of HIV, a lot of the gains that we have made over all these years have now been lost. So that in a place like Botswana, where the life expectancy went up to about 63 in the 80s, we're now back down to 47. There are some success stories. You look at places like Uganda, where the graph is beginning to take an upturn. And that has a lot to do with things like political will and political commitment. Uganda is one of those places where, from the very highest level, the president himself made a commitment to do something about HIV. So it takes more than just resources. It takes that commitment. Let's come back home and let's talk about what some refer to as this invisible epidemic. You have seen this graph, I'm sure, and will continue to see it. But essentially, what it shows you is it shows you the deaths from AIDS. It shows you cumulative numbers of individuals, and it shows you new infections. The key here is that at some point in time, in the late 90s, we came up with highly active antiretroviral therapy, a combination of medications that, remember, we said turned what was an acute situation into a chronic disease. So what happened? The death rates began to drop. And we began to have more people living with HIV. The other important things to remember are transmission categories and what is happening. We have different modes of transmission of HIV: male-to-male sexual contact, injection drug use, heterosexual contact, and then a combination. But look at this point, or these points, and look to see what's happening with the heterosexual contact as a mode of transmission of HIV. And let's look at AIDS in the African American community. This is an important issue that you must not overlook. Why is this? Because if you look at census data, African Americans in the last census represent 13% of the U.S. population. But if you look at the AIDS cases, they represent almost half of the AIDS cases. And if you also look at Hispanic Americans, who represent 14%, there's also a disproportionate representation. This is an issue that has to be addressed. And this says pretty much the same thing: percentage of the population, percentage of AIDS cases. So the question that you have to ask yourselves should be, why are these numbers like this? What can we do to make a difference? And so some look at HIV as an unequal epidemic, because we have inequalities when it comes to the issue of race. We have inequality when it comes to the issue of sexuality, when it comes to the issue of drug use, when it comes to the issue of gender, and also geographic location. But there are also issues that have to do with discrimination, education, prevention, and treatment. So I'm going to go over this one more time because I want it etched in your minds. African Americans are only 13% of the U.S. population, but represent half of the new AIDS cases and the AIDS deaths. And by the end of 2002, more than 185,000 African Americans had died of AIDS. And the other thing to keep in mind is that the poorest survival rates of all the racial and ethnic groups are amongst African Americans. They're diagnosed later, at a later stage of the disease, and they have a poorer access to the antiretroviral therapy. And I thought this graph was very, very important. The leading causes of death amongst black Americans between 25 and 44 years of age: number one, HIV infection, higher than heart disease. So let's go back to the global picture here. The issue of gender disparities is an issue. It's an issue here in the U.S. It's an issue amongst the African American communities. It's an issue in the Latino community. It's an issue globally. Access is an issue. We have very good medications. But if you look at a graph like this, and you look at 1995, at the advent of antiretrovirals, and you look at a change in the death rates of AIDS in Western Europe, and you also see this in the United States, you have to ask yourself, why is it that in some developing nations and in places like Africa, the graph continues to go up almost exponentially? That is a question that you have to ask yourself. And so some will remember this decade as a decade of despair because we have obscene economic disparities, because we have countries that have a wide gap between the haves and the have-nots. And we have 34 nations where the life expectancy has fallen significantly because of HIV. Because we have economic situations where the income of the richest 10% of the U.S. population alone is now equal to the poorest of 43% of the world as a whole. And then you have places like Brazil, where 3% of the population own 2/3 of the country's fertile land. But remember, I said it was more than just numbers. It represents lives. Because we have an impact on, it's a holistic impact. We have an impact on agriculture. We have political and economic stability issues. We have educational issues. We have healthcare issues. If the teachers are dying because they have HIV, who's going to teach the children? If the farmers are dying, who's going to grow the food? It's more than just numbers. And it's a complex issue. It's a complex issue, and I'm not going to go through each one of this. But there are things that you've got to think about. And what role will you all play? I can tell you what role I'm going to play. I can tell you what role I'm playing. And I can tell you that these experiences keep me going. But what are you all going to do? It is your duty to do something. You must take action. You all are citizens of the most powerful nation in the world. And remember, we're talking about not just health, but human rights. We need resources. We need access. And when I talk about access, there is a lot of politics that goes into the issue of access. I must tell you that there have been a lot of advances, but there is still a lot of work to be done. If you look at this, back in 1991, the annual cost per person for triple therapy was way up here at $12,000. Well, it's gone way down. So that is improvement. We have made improvements, but even with those improvements, we still have a long way to go, because the majority of individuals, even with these improvements, still do not have access. And there are lots of ways to address this issue. If you want to get into the politics of it and the economics of it, we can talk about dropping the debt. I won't go much further into this because that might take another 1 hour discussion here. But dropping the debt is an issue. Education, behavioral changes, stopping the spread. It's more than just abstinence. If you don't have the abstinence, you need the ABC and you need the CNN. You need abstinence, you need to be faithful, you need condom use, you need negotiation skills, you need needle exchange. These are issues that you've got to consider. You need to empower women. You've got to talk about female condoms. You've got to talk about the development of microbicides. You've got to talk about vaccine development. You've got to talk about voluntary counseling and testing. You've got to talk to people about knowing their status. A significant number of individuals do not know their status. And if you do not know your status, then how are you going to do something to prevent the spread of HIV? So, what can we do? We can donate funds. We can treat individuals. We can drop the debt. And we can stop the spread. Just a summary for you all. But it's important to realize that you cannot be passive. You have to take that first step and then continue to move in the appropriate direction. So we can, we must, and we will. And AIDS is the crisis of our generation. And ultimately, we will be defined by our response to it. Years from now, we will have to answer to our children. Did we stand by as millions died? Or did we take action? And I'm quite sure, and I'm quite confident, that we will make our children proud. And before I finish, I must do something for Mr. Odom here and Dean Fowler. Last night, I was thinking of what I was going to say. And I was thinking, should I give this talk from a scientific standpoint, throw in a lot of numbers, and have you all fall asleep while I'm doing it? Or should I do what Mr. Odom asked, which was to mix it up and make it a little bit more personal? And I decided to try to make it personal. But I also decided to throw in a little bit of something at the very end here to emphasize the issues that Mr. Odom wanted us to emphasize, the issue of hope, the issue of commitment, and the personalization and why we do what we do. And so I'm going to read to you something that I wrote last night. And you must forgive me because I did this on my bed, half asleep. And the title is Simply Hope. And I think this is a good segue to the next speaker, who, is she here? Yes, she is, from the Hope Clinic. So this is also for you, Simply Hope. And it talks a lot about why I do what I do and how I feel about what I do. My heart is full of sorrow, but I am filled with hope. You see, as life evolves, our journey of life becomes a quest in eternity. Today, we remember the past and we pay tribute to it. But we must live in today. And we must learn from the past. And we must build on it. We must build the bridge to the future. A bridge built with blocks of hope and cements of passion. We must learn. You must learn. And during this journey of mine, I have learned. What have I learned? I have learned that we share the pain. My pain is her pain. And his pain is my pain. But together, our hope prevails. As our lives are bound together in destiny, intertwined as powerful threads of human essence. You know, it dawned on me last night as I was sitting there writing this, that really this had to do with us as humanity. It was not them. It is not them. It is not they. It is not theirs. It is not his. It is not hers. But instead, ladies and gentlemen, listen to me. Hear me well. Instead, it is ours. Indeed, it is us. For our future, our fate is bound together. Bound eternally with hope and passion, with power, and yes, Joe, with commitment. Thank you.